everyone, this is Dr. Mansi from Homeopathy 360 back again with another session of Homeo Talks 2025 webinar series of Homeopathy 360 with collaboration to Parul University. Today we have Dr. Shailendra Bhamar sir from Rajkot Homeopathic Medical College. We are very happy to have Dr. Shailendra sir with us today. We are going to learn again on another topic. Dr. Jolly will introduce sir and the title, and then we are going to have a very wonderful session. Please, Dr. Jolly.
Hello and good evening all. My name is Dr. Jolly and I am doing MD from AHMC in Material Department. So today we have Dr. Shailendra Bhamar with us. He is working as a professor in Department of Practice of Medicine in Rajkot Homeopathic Medical College, Parul University. He has completed his BHMS from AM Sheikh Homeopathic Medical College and he has done his MD from Baxen Homeopathic Medical College, Noida. He has also worked as a medical officer at the Baxen Homeopathic Medical College. Sir has been working as professor at several colleges like Rani Dulaiya Smriti Memorial Homeopathic Medical College. Before that, he was also working at School of Homeopathy, Sihor. So, sir has much experience. So, we are grateful to you, sir, that we would be learning so much from you. So, today's topic is which sir is going to speak about is integrating homeopathy with conventional cancer care for leukemia patients. So I request you to, sir, I request you to start your session. That would be so informative for all of us. Thank you, sir. I welcome you.
Thank you for that overwhelming welcome by your side, Dr. Jolly and Dr. Mansi. I'm very much thankful to you. Before I start with my actual session, I would like to give a privilege thanks to Dr. Mehta sir, the principal of our college, Rajkot Homeopathic Medical College, and also the management of Parul University, Dr. Devanshu Patel sir, Dr. Komal Patel ma'am, Dr. Parul Patel madam, and all my faculties and my dear students, if you are listening to me. Today we'll be having a very special session on integrating homeopathy with the conventional cancer care for the leukemia patient. So I'll try to share my PPT if it is okay. Is my PPT visible to all?
Yes, sir.
Okay. So there we are with the new interesting topic, that is the integrating homeopathy with the conventional cancer care for the leukemic patients. Here we'll see what leukemia is actually, what are the different pathogenesis which takes place in a patient during leukemia, and what are the different investigations which are to be done, and how we can give a helping hand with our pathy, that is how homeopathy is helpful in such conditions. So before moving into, we should see how this lineage, how the differentiation has been done in whenever there is a kind of erythrogenesis or in the stem cells, okay? Because if we understand this kind of categorization, then only we'll come to know where the leukemia is and whether it is the acute type of leukemia or the chronic type of leukemia. If you all can see here, it is the first cell, that is the hemopoietic stem cell, is there. From there, we have the progenitor cells. Those are the the lymphoid kind of progenitor cells and the myeloid type of progenitor cells. Okay, so afterwards, then they have the committed cells, we call it as. Some where they will convert into the beta cells, some will convert into the T cells, some will convert into the granulocytes, and the other will convert into the A granulocytes. And afterwards, we'll be having the matured kind of differentiated type of the cells, which can be from the megalocytes and which can be from the lymphocytes. Okay, so if we understand this tabulation, how this has been occurring, it's very easy for us to understand, okay, what are the acute type of leukemias and the chronic type of leukemias. When I talk about the acute type of leukemia, it stands for before the differentiation of the cells. So y'all can see here, there is the primitive progenitor cells, okay, where we have the lymphoid type and where we have the myeloid type of. Here, the differentiation has been arrested. And if there is neoplastic proliferation of the cells at this level, and we see lot amount of blastic cells within the blood, then it has been called as the acute type of the leukemias. Or on the other side, if we see, we have the differentiation of the cells, we have the fine cells, we have the matured cells, and if they are more in number, then we call them as the chronic type of leukemias. Okay. So moving further, we have again we have the proliferative disorders of WBC. It can be the reactive type of proliferation, or it can be the neoplastic type of proliferation. It is not that the leukocytes are they can increase in number. Even in cases of infection, inflammation, any kind of leukemia reaction has been occurring, there also we see lot amount of leukocytes. But here, when this is the neoplastic proliferation, we have the leukemias, we have the lymphomas, but these cells are very huge in number, more than lakhs and millions in number. But one difference is they are not having any kind of function. They are functionless, they are immature type of cells, and they are the differentiated type of cells. Okay, so
Sir, sorry to interrupt.
sorry,
Sir,
yeah.
your video, actually you have not rotated the screen as that if you will do it horizontally, then screen will be more wider on the
I'm,
in the video
I'm not
recording.
getting.
So, sir, can you please rotate your mobile?
Yeah, is it visible now?
No,
Is
no,
it
sir.
visible,
You have.
madam?
Yes, yes, sir. I think, sir. I think it's still that screen is it still is in vertical. If it could be in horizontally, then it will be more wider.
Should
Yes,
I
sir.
play the
In this
screen?
way. Yes, sir. In this way.
Now it's okay. I'm visible now.
Yes, sir. You are visible.
Okay.
No, sir. Not in like that way, sir. I think your screen rotation is logged.
Just hold on a second. It's not happening actually.
Okay. Okay, sir. So, okay, no problem, sir. We can continue like that.
Okay.
Okay.
So we need to understand how we can differentiate between leukemia reaction and between the chronic myeloid leukemias and the acute type of myeloblastic kind of leukemias. So we have one score that has been called as the LAP score, that is the leukocyte antigen phosphate. This is been present in the leukocyte because this is some kind of chemical which has been produced from the leukocyte, the matured kind of leukocytes. But these are not been seen in the immature type of leukocytes. So whenever we go for this kind of test, and we can differentiate between whether it is the leukemia type of reaction or whether it is the leukemia, actual leukemia. So let's come on to the main of our topic, that is the leukemia. These are nothing but the neoplastic disorders, and they are affecting the leukopoietic tissues in the body. And whenever they are affecting this, they are causing leukocytosis. And this leukocytosis, they are nothing but these are the immature type of leukocytes, and they are in the blood, okay, and also in the bone marrow. So you all know, okay, we have different types of blood within the bone marrow, and whenever there is more amount of leukocytes within the bone marrow will undergo some kind of suppression. Okay. The etiology of this, actually, whenever we have any kind of neoplastic disorder, we don't have the exact etiology, but we do have some of the factors, the risk factors, the precipitating factors. So genetically, it has been seen in the identical twins, the Down syndrome, Mongolism, Fanconi's anemia. Okay, and even if it is because of some kind of drug effect or exposure to benzene, if it has been exposed, then environmental factors are also been there, like it happened during the bombing of the Japanese cities in the Hiroshima and Nagasaki. Those people, they are much been affected by this. X-rays, use of X-ray, radiotherapy, even this can increase the risk of uh, leukemia. Retrovirus, Epstein-Barr virus, immunological factors, everything has been related with this. Now the pathophysiology, if we see, the underlying defect is actually the unregulated proliferation of primitive cells without undergoing differentiation. That means what? They have undergone some sort of proliferation, but they are not been differentiated. They are the immature type of cells. They are the blastic type of cells. Now let's see what is acute and chronic type of. Like I already stated, how we can differentiate between acute and chronic type of. If they are related before the differentiation, before the maturation, they can be counted under the acute type of leukemias. And once they have been differentiated, they form different types of cytic type of cells, then we call them as the chronic type of leukemias. Okay, so that has been stated in the slides. Afterwards, the classification of leukemia, how we can classify. We can classify the main broad categories are the acute type and the chronic type of. So in the acute, we have the acute lymphoblastic type of leukemia and acute myeloid type of leukemia. And the chronic, we have the chronic lymphocytic leukemia and the chronic myeloid type of leukemia. So different classification have been given by WHO also, and also by the FAB classification. That is the French, American, British classification. They have classified this into the AML and ALL. So these are, I'm not going into detailing of that. Afterwards, let's see what do you mean by the acute lymphoblastic type of leukemia. I'm using the word lymphoblastic because here the cells are immature type of and very large in numbers. Okay, so it is usually been seen in the children, usually the first and second decades of their life. Okay, and males are more been it's the ratio is more in the males as compared to the females, and they usually failure of maturation has been there. Okay, so whenever there is failure of maturation, so they are not going to go into the peripheral blood smear. They will be in the bone marrow only, and they will go on collecting there. So we see some kind of clinical features in such individuals, where the clinical feature, it starts with initially there is no specific symptoms, but the patient may come up with fever, malaise, prostration, pallor. Okay, after that it can lead to the bleeding tendencies, because when this WBC cells, they have been there in the bone marrow or anywhere in the body, whether it is in the spleen or anywhere. So they are so much in number, they are going to kill the normal type of RBCs, normal type of thrombocytes. Okay, so they'll be less in number. So when the RBCs are less, anemia will have occur. When the thrombocytes are less, then it is going to lead to the bleeding disorders. And even when it is not that only the immature or non-functional type of WBCs have been there, we do have some type of the normal cells also, the WBCs, even they are less in number. So it is going to lead to leukopenia also, anemia also, and thrombocytopenia. So the patient is going to come up with all such signs and symptoms. Okay, and afterwards, they might involve some kind of neurological involvement. Meningitis can be seen. Cranial nerve palsy is also been seen. So, because the ophthalmoscopic examination, it shows the pallorness of the optic disc, venous engorgement has been there, hemorrhages has been there, exudates have been seen. So this is the presentation where you can see the blast cells, the lymphoblasts have been seen. Now, moving on to the next one, that is the acute myeloid type of leukemia. Here, the myeloid series has been arrested, where there is failure of the maturation of the myeloblast, Age group is usually the second and third decades. It is 4 times more common than ALL, and here we don't have any kind of discrimination. It is equally affected to both the genders. Again, it has been related with the infections of the gum, mouth, throat, skin. We see here, we do not see any kind of lymphadenopathy and hepatomegaly as what we see in the ALL type of, okay, because it has been involving the lymphoid series. So the spleen will be involved, the liver will be involved, and also the lymphatics have been involved. But here, it is not the case. It may present with some kind of extramedullary involvement. Extramedullary means it is out of the bone marrow. Even they have like the exophthalmosis can be seen. Then there is localized enlargement of the breast can be seen. The skin is become nodular. Okay, so even chloasmas can be seen over here. Investigations. What investigations can be done? The investigations which we recommend usually, because as the patient is suffering, it is having all types of the cells have been decreased in number. Okay, so we see anemia, we see the leukocyte count also get decreased if it is the normal leukocyte have been decreased. Okay, then there is platelet has been reduced because we see the thrombocytopenia also we see. Okay, so these are the indices what we see here in different individuals, adults, infants, children, and different age groups. The neutrophils, again, it depends on the type of the WBC which has been involved. It can involve the neutrophils, it can involve the lymphocytes, monocyte, eosinophil, or the basophil, depending on the particular cell. The peripheral smear, when we see, here we see the presence of blast cell, as I have shown you in the slide, the historical slide, where we see the large areas of the large diameters of the cell. They can be lymphoblasts. Here, special thing is there that is called as the OR rods, which is very typically seen in the acute myeloid leukemia. So these OR rods, they are nothing but whenever we are putting some kind of stain on the particular smear, like the myeloperoxidase has been put on that particular stain, then it is going to dye that, it is going to form some kind of rod-like structures, and they are called as the OR rods. And this is typically present in the acute myeloid leukemia. We don't see this in the acute lymphocytic type of leukemia. Okay, we also go for the immunophenotyping of this, where we see the varieties of the cell, whether it has involved a T cell, whether it has involved a B cell, if it is related with the acute lymphoid leukemia. Then the next investigation category is immunohistochemistry has been done. So it uses a microscope to view the labels of the immunoperoxidase. And we also go for the flow cytometry. The FISH kind of thing is also been done. Karyotyping has been done. The PCR test has been done to see whether the patient is suffering with acute type of leukemias or not. The prognosis for this, the prognosis also, it's very important. The WBC count, if it is less than 20,000, the platelet count, it is again 1 lakh or something. Absence of lymphadenopathy and hepatosplenomegaly, it is the early institution of the therapy can be done. Particular management, if we go, this bone marrow transplantation can be done. Then again, the stem cell transplantation can be done, or the patient can be sent to the radiotherapy, chemotherapy as well. So I'm going to skip all this so that now we have the next one, that is the chronic type of leukemia. Again, it is very much important because like I said, this chronic type of leukemia, we have the chronic myeloid type of leukemia and the chronic lymphocytic type of leukemia. So here we have the proliferation of the hemopoietic hemopoietic cells, usually the granulocytic series. It is again, that's why we call this as the granulocytic type of leukemia. Neutrophil leukemia, it forms 95% of the cases. Basophils and eosinophils, even they may be affected, but it is very rarely seen. Where we see this disease, usually in the 30 to 80 years, and the incidences peak at the level when the person is of 55 years. We don't see this disease below the 5 years. It is mostly common in India, okay, and usually in the belt where Chhattisgarh, Madhya Pradesh here, there we see more kind of chronic leukemia. The most common leukemic affecting adults in India, the disease is found in all races, etiology is unknown, and male to female ratio is 1:1.3:1. Then the cytogenic and the molecular aspects, 95% of the patient with CML, they have the chromosomal abnormality. This is very important that it is related with one chromosome that is called as the Philadelphia chromosome. Okay, so this Philadelphia chromosome, it is nothing but is the shortened chromosome 22, and it is the result of the reciprocal translocation of between two chromosomes, that is the chromosome 9 and chromosome number 22. There is translocation between these two where there is fusion gene that is called as the BCR-ABL gene. Okay, then etiology, again, it is having no any kind of correlation, and we don't have the exact etiology. It is related with the cytotoxic drugs or viral kind of etiology, cigarette smoking, atomic bomb, like I stated earlier, they are the same. Then when we go for the pathology of this, we see the increase in the granulocytes. Okay, so granulocytes, these are nothing but these are the cited kind of, they are the differentiated type of cells. Okay, so when the bone marrow, it is filled up with all the granulocytes, the myelocytes, metamyelocytes, promyelocytes, these all are the lineage cells which have been there. Okay, so the blast cells, they are few in number, less than 5%, because these blast cells, they get converted themselves into the differentiated cells. Then only we are going to have this in the smear. Okay, it has three phases actually: the chronic phase, the accelerated phase, and the blast crisis. So, what is the blast crisis? When it transforms into a acute leukemia, either the myeloid or the lymphocytic, which is refractive treatment, means it is not that the acute cannot get converted into chronic or the chronic cannot get converted into the acute one. It may happen that the chronic type of leukemia, it may get converted into the acute type of leukemia, and that has been called the blast crisis. The clinical presentation, how will be the clinical presentation of such persons? The clinical, it is usually insidious, because we know in the chronic cases, it is not sudden in the onset. It is always gradual and very insidious. It starts at asymptomatic type of, or all of a sudden some other reports have been done and the patient comes to know that the person is suffering with the chronic type of leukemia. Okay, and it is always related with the size of the spleen, and it is corresponding to the total leukocyte count. And the less common are the features which have been related to granulocytes or the platelet dysfunction, such as the infection, thrombosis, or bleeding, because it is related with all kinds of cells. It is affecting all the different cells also. So there may be scarcity of such cells. Occasionally, the patient presents with the leukostatic manifestation due to severe leukocytosis. If the patient is having more amount of leukocytosis in the blood, or thrombosis such as the vascular disease, cerebrovascular accidents, myocardial infarction, venous thrombosis, priapism, visual disturbances, and pulmonary insufficiency. And lymphadenopathy is usually not seen here because it is not involving the lymphocytes. Okay. Again, minimum to moderate splenomegaly is the most common physical finding, and mild hepatomegaly is fine. Occasionally, some at times we see hepatomegaly, and we don't see that much of splenomegaly as we are going to see in the next slide. How the complication of such diseases, there we see massive hemorrhage. Then the hemorrhage can be, usually it is in the intraocular within the eyes. Then there is infections, anemias, malnutrition, splenic infection will be there, deep vein thrombosis can be seen. It can lead to secondary gout or the blast transformation. Most serious complications or the granulocytes, they can get converted into sarcomas. Okay, so these are the transformations from one cell to the other cell. Investigations, total leukocytic count, 1 lakh. It may more than 1 lakh cells per cubic millimeter of blood. Differential count, it goes for different types of cells. It can be the myelocytes, promyelocytes, monocyte, basophil, etc. Occasionally, the smear, it contains only the mature type of neutrophils. They have been called as the chronic neutrophilic or the Wheels chronic myeloid leukemia. The platelet time, it may increase or be normal. Lab score is low or absent, like such. They are not the mature one. And this leukocyte antigen, it is only been produced by the mature functioning cells. So these cells are not functioning properly. That's why we don't get so much of lab score here. And we see the presence of the Philadelphia chromosome. Okay, and if we see, it is the translocation from the chromosome number 22 to chromosome number 6. What will the prognosis for this? If it leave it untreated, the survival time for the patient is usually 2 to 3 years. If we go for a good kind of treatment, the survival will be 10 years. And if all this doesn't happen, then the death, usually it is because of some sort of infections. If there is transformation of the blast cells, hemorrhage has been there, or it may be because of the bad effect of drugs which have been administered to the patient. Okay. This Philadelphia cases, they have been betterly prognosis by 4 years of survival, and etc. has been there. Then the management. In a chronic phase, how do we manage? So this BCR-ABL tyrosine, this gene is there, which is there on the Philadelphia chromosome. So it has to be inhibited, and it reduces the uncontrolled proliferation of the WBC. Accelerated phase and the blast crisis, more difficult than the supportive therapy has been given. And afterwards, we have the advanced second gene TK inhibitors have been provided. Okay. After that, routinely the chemotherapy, radiotherapy, the surgery, splenectomy, everything can be done. And we have one technique that is called as the leukapheresis. The next category, that is the chronic lymphocytic type of leukemia. Again, it has been related with the lymphocytes. So it is the most common variety of leukemia, and it counts something around 30% of all over the population. Not more in India, but it is more in the Western countries. The ratio is 2:1 in respect of male and female. The lymphocytic, it is divided into B cell and the T cell. Okay, so B cell, wherever they have been present, whether they are in the spleen, whether they are in some of the other tissues, they'll be having the effect over there. And the T cells, where they are present, like in the thymus and all, so they'll be involving such organs wherever they have been present. Okay, so the 90% cells, they are the small lymphocytes. The chromatin, it is condensed, and the cytoplasm, it is having a small to moderate amount. Okay, then the bone marrow, how the bone marrow looks in such persons, it is patchy, nodular, interstitial involvement, and it is having a good outcome. We don't see any kind of no anemia, no thrombocytopenia at the time of diagnosis. We don't see at the time of diagnosis. And then the next type of chronic lymphoid leukemia, it is the T cell. Earlier it was the B1. Okay, so these lymphocytes, they are from of moderate size with abundant light blue cytoplasm, eccentrically placed nuclei with a condensed chromatin pattern. These are the histological evidence which we see usually in the patients. Here we see the anemia, thrombocytopenia, and they have been associated with neutropenia, means the subtype of WBCs. Now the pathophysiology, what happens actually? Here, most of the cases, they are of the B cell origin. The B cells, they undergo uncontrolled type of proliferation. Then they infiltrate into the liver, spleen, and some other organs. Okay, and the disease, the B lymphocytes, which normally respond to antigen by transformation and antibody formation, it falls to do so, because ultimately the B lymphocyte, they are going to form the plasma, and from the plasma, there we are going to have the antibodies. Okay, so if these have been less in number, so they are not going to produce any kind of antibodies. So patient is going to suffer with hypogammaglobulinemia. Okay, so that is one condition which will coming afterwards. And ever increasing mass of the immunocompetent cells accumulate to detriment of the immune function and the normal bone marrow. hemostasis. So there is some kind of formation of mass because the lymphocytes have been related with some kind of massy production or mass accumulation, but the leukemias, they are related with some kind of liquid kind of flow. Okay. Now, what are the clinical features of this? The onset, again, here, as it is a chronic condition, it is very insidious. The patients, they are going for some other routine examination and they come to know that they are suffering with leukemia. Okay. So the presenting complaint, it may be anemia, it may be infections, it may be generalized pain, painless lymphadenopathy has been seen here. And the systemic symptoms such as night sweats or the weight loss, it always been accompanied with a leukemic patient. However, more often occur later in the progress of the disease. Lymph nodes, how the lymph nodes are, they are moderate to large in size. They are firm, discrete, rubbery in consistency. Especially we see these lymph nodes near about the cervical area, axillary area, and the inguinal area. It also always leads, it can lead to the enlargement of lacrimal salivary glands, and they have been associated with the mucolis syndrome. When it has been the lacrimal gland and salivary gland both have been involved, then such syndrome is called as the mucolis syndrome. Here the liver is enlarged and the spleen is not that much enlarged because, and due to the immunosuppression, there is increased tendency for the infection, especially the respiratory and urinary tract infection, because there is deficiency of the immunity. Okay, so there we see the impeccable pruritus, which is a distressing feature. Patient is suffering with itching at such times. Then the investigations, what we can go for investigations? We'll go for the blood count, the total leukocyte count, somewhere around 50,000 to 2 lakhs in that person. Mild but gradually increasing anemia. In the initial stage, we don't see that less amount of RBC, and as the time continues, it goes on increasing. Okay, so the person is suffering with anemia after some times. The platelet count is also decreased, and when we go for the peripheral smear, we see the mature lymphocytes, lymphoblasts, and these lymphoblasts are rare in number, but many lymphocytes are ruptured, and when they have been ruptured, they have been called as the smudge cells or basket cells. So this is a very specific of the chronic leukemias where the that to the lymphocytic type of leukemia where the smudge cells, when they enlarge in the size, they rupture, they burst open, and they look like the smudge kind of thing. Okay. Then the electrophoretic studies have been done. The immunoglobulin level, it should be estimated to establish the degree of immunosuppression, which is common and progressive. Then we can go for the monoclonal proliferation of immunoglobulin. Here I said there is decrease in the beta cells, the blast cells. Okay, then it is going to lead to less amount of antibodies. Then bone examination can be done, and the LN biopsy can be also be done. Now next we have the staging of this chronic lymphocytic leukemia. How the staging can be done? The staging is related with the number of sites where it has involved. Okay, like we have the stage 1, A, B, and C. Stage A, it is related with the 60% of patients. They have been coming up with such kind of stages. We don't see any kind of anemia and thrombocytopenia, but the lymph nodes, the lymphoid enlargement, it is seen at 3 areas or less than 3 areas. Next, we have the second stage, that is the stage B. It is related with the 30% of the patients. And in 30%, again, we don't see anemia, no thrombocytopenia, but the involvement is more than 3 or 4 areas have been involved where there is lymphoid enlargement. Then the third stage, that is the stage C, it is seen in 10% of the patient. Here we see anemia, here we see thrombocytopenia, irrespective of whether there is enlargement of the lymph nodes or lymphoid or not. Okay, so this is how we have staging of the chronic lymphocytic leukemia. Then we have some other categories, that is stage 0, 1, 2, 3, 4. Again, it has been related with the lymphocytes. Again, it has been related with the involvement of the liver or the spleen or involvement of the RBC or the platelets. Okay, so stage 0, it starts with lymphocyte, which have been less in number, that is more than 15,000 per cubic millimeter of blood. Then the hemoglobin percentage, it is more than 11 gram, platelet more than 1 lakh. There we don't see any kind of enlargement of lymph node or liver or the spleen. Then this is categorized as the stage 0. And in the stage 1, it is along with stage 0, we are supposed to add the enlargement of lymph nodes. Then in the stage 2, we have stage 1 along with enlargement of liver and the spleen. In the stage 3, we have stage 2 along with the hemoglobin percentage, which is less than 11%. And then we have the stage 4, that is stage 3 plus the platelet count, and which is less than 1 lakh. So these are the stages. Now let's see the prognosis of this chronic lymphocytic leukemia. The overall median survival for the patient with it is somewhere around 6 years. Majority of the clinical stage A patients have a normal life. Like I said, in the stage A, they don't have any kind of important discomfort. Between 2 and 3 years, they can survive. This is been called as the Richter transformation, and also the blast crisis. We don't see that much of blast crisis as we see in the CML. And then we have different variants, means how the different subtypes which they can be called. We have the pro-lymphocytic type of leukemia and the hairy cell leukemia. Pro-lymphocytic, it is related with the before stage, the stage which comes before the lymphocytic area. And the hairy cell leukemia stands for where the cytoplasm, it shows some kind of hairy granulation, some kind of hairy patches. Okay, that's why we call this as the hairy cell leukemia. Afterwards, let's move on into the homeopathic part. What are the miasmatic cleavage of leukemia? The underlying defect in the acute leukemia, it is the unregulated proliferation of the primitive cells without undergoing differentiation. So that goes for the psychotic miasm. Okay, so when we talk about the psychotic miasm, here there is unregulated proliferation of the cells. Okay, so here again it goes for the hepatosplenomegaly and lymphadenopathy, and it has always been associated with anemia and thrombocytopenia. So that calls for the SORA miasm. If we go for the repertorial approach, we do see some kind of rubrics within the Murphy repertory, where in the chapter of the clinical repertory, we have this that has been called as the leukemia. Okay, in that the different medicines have been indicated. Some have been italics, some have been in the Roman, and some are in the enlarged one. Okay, large one. So we have some of the medicines which have been indicated, and here they are nicely written that in leukemia, the medicines which have been given in the Murphy's repertory, they are the acid, they are the econium, they are the aran, urs iod, barata iod, calcarea, calcaraphos, carbovage, carboanomaly, cyanathus, very much indicated medicine. Chininum sulf has been there, ponium is there, cortisol is there, picric acid is there. Okay, and also we see the other rubric, that is the acute one, the leukemia in the acute, where the medicines are the arsenic, lacasis, merc, natramur, nitric acid, phosphorus. Okay, and the next rubric is the children in acute leukemia. Arsenic is very much indicated in dark color. Then we have the lymphoid. There we have arsenic iode, carbovage. Then we have cyanathus, very indicated. Phytolacca is there, Thuja is there, natramur is there. Okay, and in leukemia, if there is involvement of the spleen, then we have arsenic, we have cyanathus, we have natramur. Like this, we have many medicines which have been indicated in the Murphy's repertory. We also see some of the rubrics in the synthesis, where in the chapter of generals, they have indicated leukemia. Again, in leukemia, we have different medicines like the acid acotime, the aran, iode, okay, benzol, calcaraphos. Like that, we have many medicines. And the next rubric is in children. where the medorenum has been indicated, and in the pseudo leukemia, the ferric picric acid has been indicated. Okay, so this is the repertorial approach where how we can hunt a rubric for leukemia. Now let's see some of the drugs which have been indicated in our homeopathy. The therapeutic sites, we have arenia. Arenia is indicated in the spleen swollen, bone pains in the extremities. All symptoms have been characterized by periodicity and coldness and great susceptibility to dampness. Patient feels cold to the very bones, and coldness, it is not relieved by anything. And pain is the of the calcis, and sensation of swelling and other parts as if they are going to sleep. Okay, so this is very peculiar of arenia. Then we have ursiode. It is well indicated by profound prostration, rapid irritable pulse, okay, a recurring fever, sweats, emaciation, tendency to diarrhea, great emaciation, recurrent fever and sweats, drenching night sweats, chilly, and the patient cannot endure the cold. So these are the indications of arsenic iodide. Then next we have the Ars album. It maintains the system under the stress of malignancy, regardless of the location. Among this, the all prevailing debility is the exhaustion, restlessness with nightly aggravation, and most important, great exhaustion after the slighted exertion. Burning, which is relieved by heat, anemia, fluorosis, gradual loss of weight from impaired nutrition, reduces the refractive index of blood serum, okay, which is seen in the China and ferrum phos also. So these are the same symptoms which we see. Then we have next drug, that is the benzolam. The most striking fact in the proof of benzol seems to be the influence it had on the circulatory system. In humans, prover, it resulted in a decrease of the red and increase of the white cells. It ought to be of use in leukemia. Now we have the calcarea carp. Its chief action is centered in the vegetative sphere, impaired nutrition being the keynote of its action, the glands, skin, bones being instrumental in the changes brought about. Increased local and general perspiration, chill at 2 p.m., begins internally in the stomach region, fever with sweat, night sweats, especially on head, neck, and chest. Then we have calcarea phos. Anemia after acute disease and chronic wasting disease. Anemic children who are peevish, flabby, have cold extremities and feeble digestion. Numbness, crawling are the characteristic sensation, and tendency to perspiration and glandular enlargement are symptoms it share with the carbonate, scrofulous and sclerosis. Then we have carcinosin. It acts favorably and modifies all cases in which either a history of carcinoma can be elicited or symptoms of the disease itself exist, as stated by Dr. J.H. Clark. Indigestion, accumulation of gas in the stomach and the bowels, rheumatism, cancerous cachexia, it has been seen. Then there is cyanothus, very indicated medicine, very good remedy. This remedy, it possesses a specific relation to the spleen. Anemic patients where liver and spleen, they are at fault. There is active hemostatic, materially reducing the clotting of the blood, deep-seated pain in the left hypochondrium, hypertrophy of the spleen, leukemia, unable to lie on left side, pain in the liver and in the back. Then we have China. Debility from exhausting discharges, from loss of vital fluid together with a nervous erythism calls for this remedy. Periodicity is more marked, sensitive to draughts, seldom indicated in either stages of acute disease, liver and spleen swollen and enlarged. So these are the indications in China. Then we have the Perum picrum, that is the pseudo-leukemia we see here, is considered a great remedy to complete the action of other remedies. Natrum sulph, It is the best remedy of the liver, hydrogenate constitution. Liver becomes sore to touch, sharp stitching pain, can't wear the tight clothing around the waist, and aggravation by lying on the left side. Picric acid, indicated in neurasthenia, as we see in oxalic acid, there is muscular debility, heavy, tired feeling, progressive pernicious anemia, great weakness, tired, heavy feeling all over body, especially the limbs, and it was on exertion. Then we have X-ray, repeated exposure to X-ray, that is a raw antigen. It has produced skin lesions, often followed by cancer. Changes takes place in the blood lymphatics and the bone marrow. Anemia and leukemia. It has the property of stimulating cellular metabolism, arouses the reactive vitality mentally and physically. It brings to the surface the suppressed symptoms, especially the psychotic one, and those due to mixed infections. Its homeopathic action is thus centrifugal towards the periphery. Then we have the last one, that is the radium bromide. It is marked increase in polymorphonuclear leukocytosis. Okay, so these are some of the drugs which have been indicated in leukemia, and it mainly depends on the totality of the symptom, individualization of the patient. Okay, so these are the references where I did all this task. I have referred textbook of medicine by Dr. K.V. Krishnadas, Davidson Principles and Practice of Medicine, Harrison's Principles of Internal Medicine, Pocket Manual of Homeopathic Materia Medica, Repertory, written by William Borick, Miasmatic Prescribing by Dr. S.K. Banerjee, Clinical Diagnosis and Management by Laboratory Method, that is by John Bernard Henry. So I hope you people understood something about leukemia and the homeopathic aspect of this. Hello.
Yes, sir. Thank you so much for this wonderful session. And I would like to call Dr. Zeel again. Dr.
Okay.
Jolly.
Yes.
Yes, ma'am. Please end this session.
Sir, we have a few doubts. Can we just solve them quickly?
Sure.
Uh, Sir, the one of the attendees asking, are there any cases of
Cases of?
analysis, or your experience in any case you have treated?
See, in homeopathy, what do we see as it is a case of leukemia, or it may be any type of leukemia? Actually, we go for the symptomatic treatment. Okay, if the patient is coming up with the different difficulties, patient is having difficulty in breathing, there's anemia, there's recurrent infections have been there, then we go for the medicine, and we also start with the medicine of the anti-miasmatic, to which constitution the patient belongs, to which miasm the patient belongs, then only we go for the treatment. Is it okay?
Yes, sir. And
I can see there are 4 questions in the box. Five.
yes, sir.
Okay.
I think, sir, that one answer covered two questions simultaneously, so I'm not asking the other question. So I request attendees to ask questions if you have any, otherwise, we would end the session. Okay, sir. I think we are done with questions.
Okay.
The attendees are thanking you for your excellent presentation, and one of the attendee has also agreed with the drug like radium brom and carcinosin that they can treat leukemia in a better way. So now I
Yes.
think we are done with question and answers.
Okay,
So
ma'am.
I would again thank you, sir, for the wonderful session. You had given us the whole glimpse of leukemia and its homeopathic management. I think this sums up our session today, and I would like to thank you for the session and Homeopathy 360 for this platform for all of us.
Thank you so much, ma'am. Thank you for giving me such a broad platform for this. I'm thankful to Homeopathy 360 and thankful to Paro University and thankful to my college, Rajkot Homeopathic Medical College. Thank you so much. With this word, should I end my session?
Yes, sir. Thank you so much
Thank you so
for
much.
your valuable time you have given to us. And I hope all the attendees learned something new today. Thank you so much.
Thank you so much. Thank you all students.
Thank you. Thank you, sir.
Okay.